So it's part of the webinar series on long or post-COVID syndrome. And today we have Elaine Rohan, who is a senior CBT therapist with IAPT or Talk Changes. And she's going to talk us through her experience in Talk Changes with long COVID syndrome, and especially looking at adaptations that are being made for long COVID and treatment pathways available. So I'll monitor the chat function and try and collate all questions to the end, and then we can have those after the talk. All right, thanks, Elaine.
No problem. Well, I'm just going to share my screen with everybody. Right, can everybody see? I'm going to assume that you can. So yeah, thank you for coming today. As Miranda said, my name is Elaine Rohan. I'm a senior CBT therapist with Talk Changes in Hoxton. And I'm going to talk to you today a little bit about long COVID and the adaptations we're making to our CBT interventions for long COVID and what the treatment pathway looks like if you do want to refer patients to us for support. So just to give you an overview, first of all, of what I'm planning to cover today. So I'm going to talk a little bit first about the psychological impact of post-COVID syndrome and some of the things that we're noticing in service and also in kind of the most recent literature on the psychological impact. I'm going to move on then to looking at some of the themes that seem to be arising in mental health presentations for long COVID. The rationale for a CBT approach to helping people manage the distress associated with this condition, a little bit about the role of IAPT and adjustments in therapy techniques that we're finding ourselves doing. I've got some case examples, which I might not have time to go through all of them, but I thought it might be useful for you to get a sense of the types of cases that we work with. And then very briefly, just to discuss what support might be provided in primary care and what patients report is very helpful in primary care. And as Miranda said, please feel free to add any questions to the Q&A section or the Q&A bar to the side. So first up, I'm not going to spend very long talking about the definitions and what long COVID is, because I'm assuming that you have a pretty good knowledge about that by now. But just to make sure that it's clear kind of what I mean when I'm talking about post-COVID syndrome and long COVID. Signs and symptoms that develop during or following a COVID infection, or sorry, a COVID-19 infection that continue for more than 12 weeks. Generally, these symptoms aren't explained by an alternative diagnosis, usually presents as clusters of symptoms, often overlapping. They can fluctuate and change over time, and they can affect any system in the body. And it may be considered before 12 weeks if the possibility of an alternative underlying disease is being assessed or being ruled out. So the psychological impact of long COVID. So what we are seeing in patients presenting with long COVID, and again, that's quite consistent with the most recent literature on this. We're seeing PTSD, and I think certainly over the initial months of the pandemic, it was assumed that it would mainly be patients who had been hospitalised who might later present with PTSD. But what we're finding is it's not restricted to hospitalised patients. People are also likely or potentially may experience post-traumatic stress disorder following illness at home. We've also seen some vicarious trauma. So, for example, people developing post-traumatic stress disorder after seeing a family member being quite ill with long COVID or even acute COVID. And PTSD is something that we're also seeing in hospital staff. And we have a dedicated pathway for Homerton Hospital staff who have been affected by COVID-19 and their experiences with it. We are also seeing quite a lot of depression in long COVID patients, so people presenting with low mood, a lot of anger and frustration at the system, at the world, at their situation. And very much a loss of sense of self, a loss of sense of identity is evident in a lot of people with depression who have long COVID. OCD is something that's mentioned quite a lot in the literature within long COVID. So thinking about an increase in fears of contamination, and that might be linked to a fear of contracting another complicating infection. It might also be linked to wanting to, or feeling a sense of responsibility to protect others, such as family members or children, or even just the wider public from contracting COVID. Health anxiety, which I think has been on the increase since the start of the pandemic in the general population anyway, but particularly among long COVID patients, you may see an increased focus on those physical symptoms, monitoring symptoms quite closely, seeking a lot of reassurance, so possibly very frequently attending GP surgeries and hospitals, seeking reassurance about their symptoms. Obviously heightened worry about kind of themselves, their own symptoms, but other people contracting COVID also. You might find kind of parents checking their children for symptoms excessively and things like that. And very often you'll find that people with health anxiety might avoid any reminders of COVID or discussions about COVID or news about COVID. Insomnia, again, will be quite common in a lot of physical health conditions and long-term health conditions, and COVID is no exception to that. Insomnia might be due to anxiety, but it might also be down to respiratory difficulties, such as breathlessness, or increased pain, making it hard to sleep or to stay asleep. Adjustment disorder, as people adjust to changes in their mobility capabilities and changes in their lifestyle. And we've also seen people with neurocognitive difficulties, which I think had the potential, certainly in the early days of the pandemic, to be maybe confused with depressive or anxiety symptoms, given some of the overlap in the symptoms that people were talking about. So people were reporting kind of loss of memory or difficulty remembering things. They were reporting difficulties concentrating, which again would be quite common symptoms in anxiety and depression. But what we're seeing particularly in long COVID patients are difficulties very often with information processing and completing complex tasks. So that brain fog that you often hear fibromyalgia patients talking about also seems to be quite relevant for COVID patients as well. And again, this is something that we've seen in patients who have been hospitalized, but also non-hospitalized patients. There's also the exacerbation of pre-existing mental health difficulties. So people who already were experiencing mental health difficulties like depression or anxiety, and these conditions have been made worse by their experiences with long COVID. So I think it's useful to think as well about the relationship between mental health and physical health. And if you think about the factors involved or the features of depression and anxiety disorders, so like unhealthy lifestyle, poor diet, reduced self-care, reduced motivation to make adaptive behavior changes, less exercise and activity, misinterpreting physical sensations or misinterpreting body symptoms of anxiety as something more sinister, a lot of avoidance due to fear of pain or fear of breathlessness. And obviously we know the impact that chronic stress has on multiple systems within the body. So when you look at all these features, it's no surprise really that there is a really strong bidirectional relationship between depression and anxiety and physical health conditions. So depression and anxiety can certainly exacerbate, but can even sometimes lead to the onset of a long-term health condition. And in turn, that diagnosis of a long-term health condition or the development of symptoms, of chronic symptoms, can lead to depression and anxiety as well, due to adjustment and due to kind of all the changes that it brings to people's lives. So there's a really strong interaction between both of these. So I thought it might be useful just to talk a little bit about some of the themes that we are seeing in mental health presentations among patients presenting with long COVID. And again, this is very consistent with what we're seeing in kind of the recent literature as well. And I've got some references at the end if you're interested in looking at a little bit more of that. So the first thing that seems to present quite frequently in terms of themes is around expectations. So expectations for recovery in particular, and that expectation that most of us had, certainly at the very start of the pandemic, if it's not severe enough for hospitalisation, you should recover within 2 weeks. And that was very much kind of a public perception. It was something that was very much kind of portrayed in the media. But it did leave people who experienced long COVID, so that third option, very often feeling that their symptoms aren't valid, or they won't be believed by family, friends, or by health professionals, that they might be dismissed by people who kind of say, well, no, you should be better by now because you weren't in hospital. This obviously as well gives rise to a lot of uncertainty. So that mismatch between what people expect when they might first be diagnosed with COVID and their actual lived experience creates a lot of anxiety around, well, why haven't I better? Am I ever going to get better? Should I seek help? There's also that uncertainty given the lack of diagnostics in the early pandemic. So people are still sometimes wondering, well, did I have COVID? Is this a legacy of COVID? Or is this something completely different that might not be acknowledged by medical professionals, which in turn kind of leads to a lot of anxiety. Also that uncertainty around the perception of the NHS for emergencies only, that I think was very much prevalent during the first wave, caused a lot of uncertainty for people around, well, should I seek help, or would that just be putting an unnecessary burden? Am I overreacting? And certainly, again, in the earlier stages of the pandemic, people were experiencing conflicting information about kind of what a rehab plan might look like, because obviously we just didn't understand enough about long COVID and kind of what would be helpful and what wouldn't. There's very often a sense of abandonment that we're noticing among people with long COVID, and a perception of kind of lack of support after they've recovered from those acute symptoms. And I think that probably does go back a little bit as well, or connect a little bit to those expectations, and that expectation, well, after 2 weeks you should be better, and certainly after 4 weeks you should be better. So people are kind of feeling quite isolated as a result of that. So family and friends kind of saying, well, yes, you had COVID, but yeah, you should be better. Why aren't you better? There's also the issue that everyone, I think, is familiar with by now, of the closure of the usual support services that people might be able to access, or services that offer them support pre-pandemic, or even just social classes that people used to attend that was a source of social support, and just in general social isolation due to the restrictions are leaving people feeling quite isolated as well. And also, obviously, while we are learning more and more as time goes on about COVID-19, about the recovery from it and about the prognosis, there's still that kind of lack of clear medical information and that lack of a definitive answer, which very often patients want, and they can really struggle when actually medical professionals have to say, well, I actually don't know the answer to that. Some of the other issues that we are noticing are the impact on family relationships, in particular changed relationships roles. So it's not uncommon for somebody in a family who may have been the main caregiver for the family, for example, having developed long COVID, is no longer able to fulfill that role, and other people are having to move into that role, and that can create a lot of stress and a lot of strain on relationships as they adapt to that. There's also a need for support for family and carers of people with long COVID, particularly, I think, family members where that role might be quite new and that dynamic within the relationship might have altered a lot. Completely anecdotal, I haven't seen any reference to it in the literature, but what we've noticed in Talk Changes is that people who report or who would have described themselves as high achievers pre-COVID seem to have particular difficulties with adjusting to I guess, to kind of the lifestyle changes and the mobility and issues and restrictions caused by long COVID. And obviously, as well, a lot of people with long COVID will have had pre-existing long-term physical health conditions. And I think for these people in particular, there's a real sense of injustice over that additional illness burden that they are being forced to endure or to contend with. So given the fact that long COVID is such a novel condition, a lot of what we are doing in terms of supporting people to manage it and supporting people with the psychological impact on it comes from what we know about other long-term health conditions. So we know that 30% of patients with long-term health conditions and 70% of patients with medically unexplained symptoms will have comorbid mental health difficulties. And these, if left untreated, tend to lead to reduced health outcomes. So people are less likely to engage with physical health services if they're depressed or anxious. They're less able to manage their physical health. I work with diabetes a lot, and that's certainly something you see a lot in people who are experiencing depression or anxiety and have comorbid diabetes. There's an increased likelihood of unhealthy behaviours, so kind of diet, smoking, alcohol use, increased mortality rates, unfortunately, and poor employment outcomes. And we know that, and again, linking back to that bidirectional relationship between mental and physical health, it's quite kind of clear where some of these might be coming from. So CBT can improve both physical and mental health. So even if the focus is on the emotional well-being, that can help people to overcome the emotional barriers to managing their condition and to adjusting and accepting their condition. So CBT has been shown to increase functioning and self-care in people with physical health conditions, a reduction in the severity in disease-specific measures for diabetes and COPD. So looking at kind of diabetes distress questionnaires or the PAID, CBT has very effective outcomes on that in terms of kind of reducing the scores. And obviously there's a reduced healthcare utilisation cost if people are managing their physical health more appropriately. So in terms of CBT, so specialist LTC practitioners, so people who have psychological practitioners or CBT therapists who are working with people with LTCs will generally have specialist training, particularly here in Talk Changes. So they are able to adapt the normal strategies that they would use to include more motivational interviewing techniques. There'll be an increased focus on patients' values and what's important to the patient on a value level. They will have a much better knowledge of the actual physical health conditions, and they will also have good relationships and good links with specialist health teams, so such as ACRT, ACES, and other kind of teams within the Homerton, within the hospital. They will be able to support people with adjusting to a diagnosis and kind of changes that might arise in their physical health symptoms. And they very much focus on helping people to overcome kind of those patterns of behaviours, those patterns of thinking in depression and anxiety that in turn have a negative impact on how kind of health is managed by that particular person. So Talk Changes has been very well placed, I think, to support people with that emotional distress associated with long COVID. We have a very well established pathway for the psychological treatment of depression and anxiety or disorders within that context of long-term physical health conditions. We have good kind of working relationships and good pathways with physical health services, like I mentioned, so ACRT, the Diabetes Centre, ACES, and we have traditionally kind of had good working relationships with those teams kind of across the hospital. We are able to provide a psychological assessment, so assessing the impact of long COVID on people's mental health and emotional distress. We're able to liaise and refer on to other services as needed. We can signpost to other community resources or community groups if that's indicated. And we obviously provide psychological treatment within the team as well for depression and anxiety disorders within the context of those physical symptoms. So, and that again would be delivered by kind of specially trained CBT therapists or PWPs who have attended, who have postgraduate training in the treatment of long-term health conditions. For patients referring for support with long COVID, the usual IAPT exclusion criteria will apply around severe and enduring mental health disorders, patients with high risk or cognitive impairment that would impact their capacity to engage in CBT. So in terms of the process, so most of our referrals are actually online self-referrals, and I've added the website address there as well. The second most frequent mode of referral is GP referrals, and that's the email address that you can send the referral form to if you need to. And then the rest of the referrals tend to come from other health professionals, so ACES, ACRT, cardiology team. We also get referrals from midwives, health visitors, diabetes nurses, anybody really who has a patient who they feel needs psychological support. So just in terms of kind of looking more specifically at what we offer for people with long COVID. So as you may know, within IAPT, we work within a step care model with the general principle of the least intrusive intervention first. So step 2 is used to refer to the treatment that we offer for mild to moderate depression, general anxiety, panic disorder and phobias. And that involves 6 sessions of CBT-based guided self-help, where patients are supplied with self-help materials around their particular problem. And then they have a weekly 30-minute session with a psychological wellbeing practitioner who supports them in implementing that self-help advice. So the 3 main interventions that we would offer are behaviour activation for depression. So we adapt that for long COVID by including additional psychoeducation, by supporting people within behaviour activation and activity scheduling to pace their activity levels, so that they're not getting stuck in those boom and bust cycles, which I'll talk a little bit more about in a few minutes, and also focusing very much on values around goal setting and helping people to kind of adjust their objectives and their goals from what they might have been striving to achieve pre-COVID to what's actually in line with their values right now. That might be something that they would find helpful. In terms of panic, again, this is something that we're seeing in long COVID patients, particularly among people who are experiencing breathlessness. So we would offer, again, 6 sessions of graded exposure and habituation for panic disorder. And the adaptations that we would make to that for patients with long COVID would be very much to account for the physical limitations of those exercises that people would be doing in between sessions. Excuse me. Worry management. So worry management is traditionally used at step 2 for the treatment of general anxiety disorder. So they would be working on things like letting go of worries, problem solving, focusing on the present moment, mindfulness, relaxation strategies. So again, just adapting these slightly to cope with more COVID specific worries and anxieties has been quite useful. We do offer computerized CBT as well at step 2, and we've got additional modules that we use for chronic heart disease, chronic pain, diabetes, lung conditions. We haven't actually used those to date for patients with long COVID, but certainly I think that there's modules in those programs that would be quite useful for them, particularly around managing breathlessness and things like fatigue and things like that. We do have plans in the new year to start to deliver psychoeducational workshops as part of the new COVID rehab service that's hopefully being set up. So I guess most long COVID patients that we've seen so far in talk changes don't they tend to be a little bit too complex and a little bit too severe for step 2 work, and most of them do end up receiving CBT. So we can offer up to 12 sessions of cognitive behavioral therapy for moderate to severe depression and anxiety disorders, so PTSD, OCD, health anxiety, and as they interact with long COVID, and thinking back to kind of the impact that long COVID might have on the exacerbation as well of pre-existing mental health problems. So what do we do? How do we adjust our very structured, very standardized CBT protocols to support people with long COVID? So one of the first things that we do is we spend a lot of time listening and validating the patient's experience, acknowledging that no two patients' experiences of long COVID are going to be exactly the same, and just really making sure that that person feels heard and listened to and understood. We will look at behaviour activation and activity scheduling as part of CBT. So particularly with chronic pain, fatigue, breathlessness, looking at pacing. So helping people to understand that, yes, they might actually still be able to achieve the things that they were able to do pre-COVID, but just at a slower pace, taking more regular breaks. And helping people to figure out, well, what is the maximum amount of time that is helpful for me to stand while I'm cooking the dinner before I have to sit down instead. And helping people to work that out first, and then helping people to implement it so that it becomes part of their routine. And so again, kind of, I guess, just kind of common methods that we would use for change, like that paced activity, like mindfulness, values-based goals, just adjusting them slightly so that they fit this particular person's individual experience a little bit more. We obviously we can also introduce medication adherence into the sessions as well. So thinking about, I guess particularly it would come up if people were struggling to adhere to medication, helping them to identify and to overcome maybe some of the thoughts that they might be having when they think about their medication, and some of kind of those more intense emotions that might be preventing them from adhering to a medication regime, and likewise with a diet regime or an exercise regime or whatever else has been prescribed. A lot of time with long COVID is being spent helping people to discriminate between physical symptoms and anxiety symptoms. And that can take several sessions. It can involve kind of keeping very detailed logs of physical symptoms, including kind of, well, triggers, what were you doing at the time when you noticed this, how long did it last for? It can involve active behaviour experiments in the session where they might test out different activities to see if there's a physical exertion, and then you can kind of assume that that's due to kind of a physical symptom or an anxiety symptom. So there's lots of different ways that we will work with patients over sometimes a prolonged period to help them to discriminate between those physical long COVID symptoms and anxiety symptoms. And again, like I said, kind of creating a lot of behaviour experiments to help them to reduce those safety-seeking behaviours that might actually be reinforcing some of their anxiety. So I thought it might also be helpful just to have a look at some of the factors that are associated with less successful adjustment to long-term conditions in general and more successful adjustment to long-term conditions. And I think it's probably fair to say that most of these will also map on to long COVID. People who tend to be less successful in adjusting to long-term health conditions have very often very specific beliefs and thoughts relating to illness. They might feel quite helpless around their illness self-management and feeling that they have no control over their symptoms or over the management of it. And they might have a very strong overlap between their sense of self and their sense and their actual experience of the disease. So, for example, if you might have somebody, as I mentioned earlier on, who defines themselves as a very high achiever, somebody who gets things done, who looks after others, who's a good multitasker. And then this disease comes along and suddenly they're not that person anymore. They're not that person who gets things done, who people come to for support. Instead, they're having to ask for help and to seek support from others. And that can be a massive adjustment for people in terms of their sense of identity. More generally, you tend to see a lot of rumination. So thinking back to, well, why did this happen to me? What if only I had done X, Y, Z at this point? If only if only somebody had noticed this at this point? If only I hadn't cancelled that appointment for that X-ray? If only Boris Johnson hadn't locked us down a week earlier? So lots and lots of rumination and kind of if onlys you will see in patients with long-term health conditions, particularly in depression. There'll be a lot of often cognitive avoidance and denial. Not so evident so far, I think, with long COVID, but certainly with other long-term health conditions. Very common in diabetes, for example, where people just want to avoid any kind of reminders or any memories of diabetes, which includes which can obviously impact then on medication adherence and lifestyle changes. And just a general sense of hopelessness and fatalism will often be associated with that less successful adjustment. On the other hand, people who are more successful at adjusting and accepting physical health conditions will seem to have more balanced beliefs about symptoms, illnesses and management. So less of that tendency to think in terms of all or nothing. So tending less to think that, well, I can achieve all of these things, I can do all of these things, and if I can't, then I'm a complete failure. People who adjust instead will be able to be more compassionate, I guess, in their beliefs about their ability to manage their symptoms and being able to say to themselves, well, I wasn't able to do everything that I wanted today, but I was able to do X, Y, Z. That's quite an achievement given my pain levels, etc., etc. So just being a little bit more balanced in the way they think about their illness. They will have greater kind of cognitive flexibility to do that, but also just a general sense of acceptance of the situation that they find themselves in and doing their best to work with the resources they do have instead of focusing on the resources that they've lost. They also tend to be more mindful, so thinking more in the present as opposed to their mind being in the past or the future. General high levels of self-efficacy obviously would be very well documented among people who adjust better to physical health conditions, and they just seem to have a better ability to reframe their situation, which links back in again to that cognitive flexibility. Looking at the behavioural factors that seem to influence adjustment to physical illness, less successful adjustment tends to be associated more with less helpful responses to symptoms. So people getting stuck in that boom or bust cycle where you find that people will wake up, they feel slightly better, so they decide to do all of the housework that they haven't been able to do for the last 2 weeks while they've been unwell. And then because they have exerted themselves, they wake up the next morning and find themselves having to stay in bed for another week again. And that cycle kind of keeps maintaining itself. They will often try to maintain previous levels of activity despite the fact that that's physically really difficult at the moment. They might prioritise one physical health condition at the expense of another, or they might find it really difficult to talk about their condition. And again, I'm not so much, I think, possibly with COVID so far, but definitely it's something that you notice in other health conditions like diabetes, where people might have a certain sense of shame or embarrassment around it, that they wouldn't disclose to family and friends that they have this condition. They tend to be more passive in how they respond to things, which obviously would be associated with that kind of external locus of control as well. And they tend to cope with things, or their coping strategies tend to be more emotion focused. So wishful thinking, a lot of avoidance of kind of triggers or memories. Whereas people who tend to adjust more successfully, they are more likely to engage in positive health behaviours. They're more likely to have higher levels of self-compassion and better problem-solving skills. They're usually better at accessing social support, and they're usually have a greater awareness of emotions and also a greater ability to express and talk about emotions than perhaps people who struggle more with adjustment. So just before we finish, I thought it might be good to introduce you to a few of the cases that we are seeing at the moment in Talk Changes with long COVID, just to give you a sense of the type of support that we can offer. So the first one is a 32-year-old lady. Excuse me. She had COVID symptoms in March, but at the time she was unable to secure testing. She did have general anxiety disorder pre-COVID that was never treated. She described herself as, oh, I was always a bit of a worrier. But since having COVID, she has developed panic attacks and quite frequent panic attacks. In terms of ongoing physical symptoms, she's having ongoing unpredictable periods of breathlessness that can last days or weeks. She's really struggling to manage the uncertainty around her diagnosis and around the prognosis, and just not knowing if she had COVID or if she didn't. Is this something that will get better, or am I going to be like this forever? Is this long COVID, or is this something else that's not being picked up? So there's a lot of uncertainty and anxiety around that. She also presented with a belief that breathlessness would lead to further complications of her condition, which in turn led her to start avoiding exertion and stopping exercising. Her partner was quite supportive, but obviously, as we've discussed, he was always also struggling to adapt to how unpredictable her symptoms were and how difficult it was to plan or prepare for anything. So this lady is still in ongoing treatment, and what the treatment looked like for her in terms of how we adapted the standard CBT protocol for panic. So again, spending a lot of time during that initial session just validating her experience and acknowledging the lack of knowledge about long COVID and what it is and how it's going to end up for her. A lot of time then on distinguishing between physical symptoms and panic symptoms. So a lot of psychoed, and like I mentioned before, spending a lot of time helping her to learn herself what's anxiety and what's physical, based on keeping logs and records, doing behavior experiments and things like that. So she also had some interesting beliefs about worrying. So, and again, as I mentioned, she did have general anxiety disorder pre-COVID as well. So this belief that worrying will help me plan for things, worrying will help me prevent a relapse, worrying will help me prepare for things, all had to be addressed in order to try to support this lady to be motivated to stop worrying. There was a lot of beliefs around abandonment. So the standard ones that I've mentioned earlier. So nobody believes me, everybody is fobbing me off. Looking at helping her to learn how to tolerate that uncertainty, it's not very nice, but it's okay and it's manageable, and it doesn't mean that the worst thing is going to happen. We just need to learn to sit with that uncertainty. She then looked at behavior activation, incorporating some paced activities. So trying to maintain consistent activity levels, increase social contact, and increase that pleasure on those self-care activities. Excuse me. And finally, behavior experiments, the bread and butter of CBT, but again, adapted very carefully to take into account her physical health conditions. So these were designed to challenge beliefs about how others would respond to either her disclosing her symptoms, demonstrating her symptoms, not being able to do things, and also behavior experiments to test out her beliefs about her capacity to tolerate these symptoms. So again, she's still in treatment, but it's just to give you an idea of the kinds of things that we will do to support people with these presentations. I'm not sure how I'm doing for time. I'll just do one more case, and then I'll move on to the final part of the presentation. Then we can go to Q&As. So the next case, I'm going to skip this one actually and go to the next one because it's slightly different, or it's more different. So again, this was a self-referral, 48-year-old gentleman who was hospitalized for 3 days in May with COVID symptoms. Still has ongoing symptoms of breathlessness and fatigue in particular. And this gentleman, unfortunately, has PTSD following his experiences in hospital. So he's having nightmares and flashbacks of the hospital, lots of avoidance of reminders of hospitals. So he was avoiding medical personnel, doctors, he was avoiding any news about COVID or TV dramas around hospitals, irritability, arguing and snapping at family members, that heightened sense of threat, and just very aware of threat consistently, and vigilantly monitoring his symptoms, his physical symptoms, for signs of relapse or out of anxiety that he might need to go back into hospital again. So again, in terms of adaptations to CBT, very important to validate his experience and his symptoms, normalise his anxiety around the prognosis, but then moving more towards a PTSD model and explaining what's happening in your brain, how is your memory affected when you have PTSD, looking at the fight and flight response and the impact that has on memory processing. Moving on then to gradually reintroducing some activities, and again, given the symptoms of long COVID, doing this in a very paced way so that he wasn't going to overexert himself to the point where the exercise would become futile because he wasn't going to get any pleasure or enjoyment out of it. Looking at trauma-related beliefs around control, in particular, and around safety. And finally, reprocessing those trauma memories to incorporate more adaptive beliefs relating to the trauma. So I thought it might be useful as well just to add in some reflections that have been noted in the recent literature from long COVID patients around the support that they've appreciated in primary care. So from one of the studies by the National Institute for Health Research, patients with long COVID reported that they had a massive sense of relief when they finally found someone in the medical profession who listened and acknowledged their symptoms and just spent time saying, this sounds really, really difficult. All of these symptoms are really, really difficult to manage. And this is what other people are reporting too. They also found it helpful when medical professionals were flexible in how they describe symptoms. So moving away, I guess, from that notion in the earlier days of the pandemic where, okay, well, you should, if you have COVID, you're going to have a cough, a fever, and a loss of sense of smell. So moving away to that and acknowledging that the COVID symptoms are flexible, that they can present very differently and from person to person. And also being flexible in the advice they're given about what recovery is going to look like. People found it difficult, but they did acknowledge that there is a lack of knowledge, that there is an unpredictability in how their prognosis and how their recovery is going to look. And while it can be, I suppose, almost disempowering for some people to have that stated quite bluntly, other people actually found it quite helpful when doctors were able to say, this is what we do know, but unfortunately, that is all we know. And this is what we think, and this is what we're not sure about. And people felt more supported by, I think, probably that acknowledgement of lack of knowledge around what COVID is and isn't. They also found it reassuring when people were able to give them accurate information on the range of symptoms, and when they were able to give them accurate information on coping resources. And I've included a resource list on the final slide that you might find useful to look at. So I guess the challenge for primary care professionals, whether it's GPs, whether it's community nurses or anybody working with these patients, is how do you promote engagement? How do you encourage people to engage with the mental health profession, with the mental health referral when they are presenting with very real, very valid physical health symptoms? How do you present that to them in a way that doesn't imply that, oh, it's all in your head? I think that can be something that can be quite tricky sometimes with patients with long-term physical health conditions, particularly frequent attenders. And I guess kind of what can be useful is to avoid that diagnostic and psychiatric language. So use their language, use their terminology, use the language that they use to describe their symptoms and their distress. And again, like I keep talking about, so validating their physical experiences, validating the uncertainty, and also the emotional toll of the illness. So asking them so listen to their story of their physical complaints and then say, so how does that affect how you feel emotionally? How does that affect your anxiety? Acknowledge that sounds like it's been a really difficult and emotional journey. In terms of kind of engaging people with an onward referral for a mental health assessment or a psychological assessment, there's, I suppose, the tried and tested salesperson pitches. So acknowledging we're trying everything that we can to help you to manage your physical symptoms. What else might help you to manage your distress with while these symptoms continue? Sometimes when people are feeling distressed because of their health, psychological treatment can help. What do you think about that? Do you think that there's a possibility it might help? If there's even a small possibility, is it worth giving it a try? And I guess the idea is if you can get people to accept that telephone assessment, that telephone call, that 45-minute call, just to explore their options, we will try and do the rest. And hopefully we can continue to kind of provide as much support as we can for these patients. So that's me. I'm going to stop sharing. And I am unmuted, obviously. Okay. So do we have any questions, everybody?
So there are a few questions on the question and answer. Firstly, thanks, Elaine. That was a really fantastic talk, and great how you've made the adaptations as well. Sound fantastic. So the first question was, how long will it take to have CBT in a long COVID case?
Okay, so
my add-on to that question is there a longer wait to get access to an LTC specially trained therapist as well?
I was actually anticipating this, so I made a point of checking this morning exactly what the waiting times are at the moment. So at the moment, the waiting time for assessment is 1 to 2 weeks. The waiting list for non-LTC, so kind of just standard CBT, is 9 weeks. And for long-term health conditions cases, the waiting list for treatment post-assessment is 2 to 3 weeks at the moment, and that will include the long COVID patients. At step 2, the waiting list is about 2 weeks. So for the 6-session guided self-help interventions.
And just my own question again, when would you think it was acceptable to start referring of someone that would you say you have to wait till 12 weeks, or is it appropriate to think about it some or much earlier?
Yeah, fine. I think it's definitely appropriate if people are distressed, if people are acknowledging their stress and they want support with that distress, then certainly send the referral through as soon as that's named and that's acknowledged. And we'd obviously do the assessment and then decide whether it would be a COVID-focused intervention or something different.
Okay, great. And then the second kind of group of question is whether in your experience you're finding that long COVID presentations and management is looking different from other kind of post-viral presentations. An example given has been glandular fever. And then where does it kind of fit with the chronic fatigue picture? We are having a separate webinar on fatigue, but just in your kind of CBT experience.
So I think the thing with long COVID, is it seems to be anything is possible. And I don't know if you've experienced that as well in the patients that you're seeing in general practice. So definitely chronic fatigue is something that we're seeing a lot of. So people, I think it's something like 55% of people who have been hospitalized with COVID are still experiencing fatigue 3 months later, or I think that's the number. And I think the breathlessness, I think, is even higher than that. Now, obviously, that might not reach kind of medically significant levels, but it's certainly something that's been recorded in kind of the recent literature. In terms of the difference, I think it's more about looking at the commonalities and the overlap, because each long COVID presentation seems to be slightly different. Some people will be affected more by the brain fog and the memory problems. Other people will be affected more by that fatigue. Other people will be affected more by breathlessness. Some people will have a combination. Sometimes people will be breathless one week, the next week they'll be tired, the next week they'll have both. So it's really constantly changing, and we're having, and like yourselves, I'm sure, having to really work on your toes and be very, very flexible with what people are presenting with to adapt interventions around that.
Great, and that seems quite unique to COVID, does it?
From what we've noticed, I think, and I think kind of from what seems to be accounted for in kind of the literature that's come out over the last 2 or 3 months on it, that seems to be kind of the general presentation. It's fluctuating. It can affect one or many kind of bodily systems. It can change over time. People can sometimes feel like they've recovered and okay, fine, I'm finally out of this, and then the next week they're back in bed, not able to breathe. So it's that unpredictability, I think, that's really quite a defining feature of long COVID, or it seems to be so far anyway.
Great. I don't know how to unmute you, Will, but does that answer your question?
Maybe type the answer.
Yeah. I think we'll have to hope yes. So we've just got a couple more minutes. If there are any other questions. Oh,
I have just unmuted Will so that he can speak.
Okay.
No, I think you're all good.
Okay, perfect.
Hello.
Hello.
It's actually not Will, it's Joe Heyman, and for some reason my login was my colleague Will's, but yes, you've answered, and thank you very much.
No problem.
Great presentation, thank you.
You're welcome. Anyone else? Okay. Well, as I've said, will copies of my slides be sent to everybody so that they can access kind of the resource list? And
yes, absolutely. Yeah, I will add those to the education library on the GP intranet, and I will also circulate them to attendees, and we'll put the recording on the video library as well. So absolutely, you can access all of these resources.
That's great, thank you. So yeah, if you do have patients with long COVID or suspected long COVID, just having those conversations around emotional distress can be really useful. And if that does arise and you feel like people need further support, please send us a referral using the email address that's in the slides.
Thank you so much, Elaine, and thank you, Miranda, as well. Miranda, sorry, Elaine.
That's okay. No, keep going.
I was just going to say, Miranda, is there any kind of final comments or anything you want to add before we close off? I do want to alert everyone to obviously the upcoming session that we will have on long COVID and fatigue, which is going to be on the 16th of December. So please do register for that. And
then we're also planning in the new year a case study webinar, aren't we?
Yes, okay. Yes, I think so. Yeah, I think I'm trying to pin a date down for that.
Yeah.
So please do keep an eye on the GP website. I appreciate that the COVID education events have tended to come up a little bit last minute, but that's just obviously, you know, the nature of what we've been kind of dealing with, and we have tried to go out to you with those dates as soon as possible, and most of these sessions are accredited as well, so really great for you to join. So thank you so much again, Elaine and Miranda. Thank you attendees as well. I will stop the recording now.